at presence of pain and worsen pain. And Heidi, if you're on the line, let me know. And hopefully everyone can hear me loud and clear. And you can see my screen without any interruptions. So we're going to begin in just 1 minute. All right, so we're ready to begin. Hopefully you can all see my screen. If you do have a problem, please click in the chat and just let me know that you're on board. And we're going to go through looking at the presence of pain. So let's begin. And I seem to have a little bit of trouble getting to my screen. But I will be there in a moment. Okay, just let me start my screen up one more time. I'm having a little bit of trouble about the navigation part. There we go. Okay. Sorry about that. Now we are ready to start. So we're looking at two indicators today. One is, and both are related to pain. One is the presence of pain, and the other is where there's an increase in pain that the patient is experiencing. As we have shown each and every time, there are two types of indicators. One is a prevalence indicator, and then there are incident indicators. And incident indicators look at both improvement and decline. And so today we're looking at the presence of pain, and we're going to look at decline in pain. Once again, please recall that these three exclusion factors are in place. This looks at every single assessment sent to CIHI, and if that assessment is not associated with a length of stay of 93 or more days, then the individual will be excluded. If the assessment is a full assessment, it will be excluded. And then we know that only the last assessment in each quarter is used. So if you did a significant change in status in a quarter, then the prior assessments would not be used. Only that very last assessment in the quarter would be used for reporting purposes. We also know for the incident indicators where we need two assessments, one to look back at. The first three exclusions are the same as for the prevalence indicators where there's only one assessment, but there's another condition. if the assessment is must be at least 45 days ago. So if it's not at least 45 days old, then the assessment will be excluded from the calculation. And if it's more than 165 days ago, it will be excluded from the calculation. And we've talked about population risk adjustment on our last series, our last day together. We will look at that and go through how the population risk adjustment is calculated in order to make sure that you're being fairly compared to the provincial numbers, to other nursing homes within your region, or to other nursing homes within your corporation. Rolling for quarter, again, every report in CIHI, even though they say 2017 quarter one, they are still reporting on a full 12 months of data. So the quarter one quarter as well, the 3 months, and then all the 9 months prior to that. So please remember the rolling for quarter. And I've done this example several times, so I'm hoping that we do remember it, where I run a report at CIHI for a particular quarter, and you can see it shows me here that there's 12 months of data altogether that is going to be used, and 3 of those quarters come from the previous report that I ran in the prior quarter. So once again, if your numbers aren't changing very quickly, even though you've made huge improvements, please remember it takes a long period of time for these other quarters to work their way out of your reports. And then for the incident indicators, we talked about having 1 extra month, a quarter in the calculation. That's just so that this quarter can look back at that quarter. The actual denominator or the numbers are not included in the final report here. So it's still a rolling 4-quarter average that we're using. Today we're looking at one of the prevalence indicators of the 12 that we have. You can see the ones that we've already covered, and we're looking at pain today. So it's just one assessment where it's a prevalence indicator. We haven't looked at any of the improvement indicators as of yet, and we'll be getting to those in a bit. And from the decline indicators, we can see indicator number 12, worsen pain, is the one that we're looking at. And we've already covered worsen stage 2 to 4 ulcers. If we go to the current averages, you can see for worsen pain is one of the 13 indicators that we track. And I track these 13 indicators because they include the Health Quality Ontario benchmarks, as well as the current provincial numbers, and then sensitivity to practice. And notice here that from that Carol Esterbrook paper that was published in Canada, coming out of University of Alberta, we can see that pain is one of the areas that nursing practice has a great deal of control over. So you can see it's the second highest factor. Pressure ulcers being the highest factor that you have control over, and pain being the second highest. Now, from the RAP point of view, there is no RAP related to pain. However, if you're doing the caps, then there is a pain cap that we can use. Okay? So we'll be looking at all of those as we go through. Now, some definitions. These are some clarifications that CIHI's made, and we need to go through looking at this. So the first CIHI clarification on the eQuery webpage had to do with pain and PRNs. And the question was, if a resident complains of pain and is given a pain analgesic with good effect, should we capture the pain in J2A? Now, this question isn't really complete, because I think what they're saying and what CIHI assumes in their answer is that during the observation window, so during that 7-day observation window, if the person experiences pain, then during the same observation window is given a PRN analgesic, should we capture it? And here the answer is yes, we should capture it. Okay, it's simply because they express pain at any time during the interval. So even though subsequently the PRN worked, they still experience pain in that interval. Okay, so it's important to capture all pain in order to ensure appropriate pain relief interventions are addressed in the care plan. Now, the next question that was answered by CIHI dealt with pain frequency. And they wanted to know how was the item J2A pain frequency coded for a resident whose pain is completely controlled by medication. And I think we know the answer here. The intent is to capture the frequency or signs and symptoms of pain if the resident is completely pain-free because they're on a medication regime that provides complete pain relief. You would code no pain. All right, so again, this is a question. If the person was asked during the observation window, which is very important, and at no time during that observation window did they experience pain. And remember, you're asking this question or answering it after the ARD date. So the ARD date's already happened. You've already got all 7 days of observation, including the ARD date is the last day of observation. And at no time during that 7 days was there an expression or a documentation related to the resident receiving pain or having pain. So you would code no pain. Section U, medications, captures all medications that the resident has taken. So in reviewing assessment, the reader should note that the resident receives pain medication and has no pain symptoms. Now, we're going to be using a scale as another one definition, and the scale is called the pain scale, which is one of the performance or outcome measures that we look at when we're assessing someone's RAPS or the CAPS, and we're designing a care plan for a person. You can see the scale goes from 0 to 3, where 3 is maximum pain, so it's severe daily pain, and a 0 means there's no pain. So if J2A, which is the pain frequency, and J2B is the intensity of pain, is excruciating, then we're going to give him the maximum score, severe daily pain. However, if J2A is still daily, but J2B says they're either moderate pain or mild pain, then we're going to say daily pain, but it's not severe. And then if the frequency is less than daily, okay, then the pain scale is going to be 1 less than daily pain. Else, if J2A equals no pain, then we're going to say no pain on the scale. So that's the scale we're going to use, and you'll see that when we do calculate the change in pain, whether or not the person's pain is increased or declined. Okay, so another definition from CIHI on the pain scale had to do with phantom pain. So is phantom pain captured in J2 and J3? Pain site. So what is the location of the pain, where we talk about the back or the legs or whatever it happens to be. So here we're going to say yes, you're going to capture pain in J2 for part A and B, and then in J3 you're going to put it under other pain, the item J3J. Okay, so that's very important to note that we do that. Okay, so we're looking at pain from that point. One more definition on the pain scale, and this one has to do with mouth pain. Is mouth pain captured in both sections K1C, mouth pain, and section J3, other site? And here they're saying yes, mouth pain is captured in both sections. K1C for mouth pain and J3. So where does that leave us? Some exclusion factors. Now you can see for the prevalence indicator, there are no exclusions except for the ones we've already mentioned. That's the length of stay, being 93 days or more in order to be included. That's the other two indicators, those general exclusion factors that we talked about at the beginning. Now for the worsened pain item, if the prior assessment pain scale is already maximum, so on the last assessment, if they had maximum pain, obviously the pain cannot get worse than the maximum. Also, obviously, if there is no prior assessment to look back at within that 45 to 165 day window, then we also will not be able to include those assessments as well. Okay, so these are the triggers. You can see here frequency of pain, where it goes from 0, no pain, pain less than daily, and then pain daily. And then the intensity of pain is mild pain, moderate pain, and sometimes when pain is horrible or excruciating. And I've just blown it up here so that you can see it a little clearer. But you can see that it comes under item J2, pain symptoms. And then J3, which is not really part of this quality indicator, but that's the J3 that we're referring to earlier. Then we have the actual calculation. So for the presence of residents with pain, all we're looking at is one of two conditions. Either condition will have us trigger the quality indicator. So you can see here, if the pain frequency is daily and the pain intensity is moderate, then we're going to trigger the quality indicator. Or if the pain frequency is intensity, is excruciating, then we will also trigger that regardless of the frequency. So whether it's less than daily or daily doesn't matter. If it's excruciating pain, you're going to trigger the indicator. And then for those who worsened or on this particular area, we're looking at the current and the prior assessment. So here we're looking at the current pain scale, and recall that we were using the pain scale that we looked at before that went from 0 to 3. If the current pain scale is greater than the prior pain scale, then obviously there's more pain. Okay, so those are the calculations. Very simple, very straightforward. There is not a RAP that's related to this in Canada. Now, I should say in Canada. If you have the Medicare software, you know there is a pain RAP. And I'm not sure if the point-click software or the GoldCare software have the pain RAP. I have not seen it myself. There is also the pain cap. Now this one is in the point-click care software for sure, and I'm not sure of the GoldCare system, but in the point-click care and the Medicare system, there is also the cap and the RAP. So you can see now we're taking 3 levels of outcome instead of just 2 that a RAP normally has. It's either there or not there with RAPs. Here we're looking at it's not triggered. If it's a 1, it's medium priority trigger. And if it's 2, it's a high priority trigger. Okay, and then we can see down below the calculation that we're using in order to calculate the cap. And again, we're looking at J2B, okay, about whether or not it's excruciating pain. Then the pain cap is going to be a 2 right off the bat, okay? So it's high priority if the person has excruciating pain. Whether it's daily or less than daily doesn't matter. Now then on the next part of the cap, in order to be a 1 where it's a medium priority, here we're looking at J2A is equal to 2, that's the daily pain. And here we're looking at whether or not whether or not it's mild or moderate pain. And then they're going to be a 1, and that means medium priority. And then else the cap is going to be 0. That is, it's not triggered if they don't meet the 2 above conditions. So from a funding point of view, pain is not funded, or directly or even indirectly. I suppose that you might think of it, well, if a person has a great deal of pain, there's probably ADLs that need to be managed, and there's probably meds that need to be managed, and so forth and so forth and so forth. So indirectly, it may be funded, but not directly with the pain indicator itself, which I would like to still see if we're providing treatment, pain treatment, then and whatever number of ways we're doing that, whether we're doing it behaviorally or whether we're doing it through a medication, somehow the MDS should acknowledge that, and that should be the funding component. And then not just the presence of pain, which is a quality indicator. So we saw already that the quality indicator is fairly straightforward in the calculation. There are 2 of them related to pain, and that there is no RAP in Ontario, although there is a RAP that was designed by the by the American group who have implemented MDS in the United States, and the pain RAP is used there along with the constipation RAP. However, the CAPS do have a measure of to assess the risk for pain. And then, of course, you see here that there's no direct relationship to the funding model. Now, just a couple of other things, and since we've got a bit of time, what I would like to look at is the Health Quality Ontario webpage, and it's just a good opportunity right now to be able to do that. And so if we can just look at the health quality page, you can see that you can go to the Library for Health Quality Ontario, that it's going to give you the different indicators that are part of the quality indicators, and you're going to be able to see what the standard is from what Health Quality Ontario is providing for you. So let's just have a quick look. You can see here that when you go in to find an indicator by keyword, it gives you the name of the indicator, what the observation window is for the indicator. It gives you a description of that indicator, all the definitions for each and every indicator. And you can see here that we're using O4A as this is a particular indicator called the antipsychotic use indicator. So, but that pain indicator is not part of the health quality group at this point, but you can see here that we have the use of medications, antipsychotics. It also tells you the exclusion factors here, so you get a detail on that. And this is that population risk adjustment. So here's where you can see the description of the factors that are used to population risk adjust the indicator. So in the case of the antipsychotic, you can see there's a scale called motor agitation. There's another one called moderate impaired decision making, long-term care memory problems, cognitive performance scale comes into this also, the antipsychotic indicator, a combination of Alzheimer's or other dementia, and also people under the age of 65. So these are used to predict what your antipsychotic rate would be, okay, given that you have these factors involved. And that's where if you're above an expected number for those types of indicators where you have a much higher risk, then those are the factors that are going to predict what your score should be, and then that factor is used to compare it against what you actually experienced. Now, the other thing is that, and we haven't talked about this, but we will again later on, and that is the direct standardization, they call it. But what they're talking about here is the case mix index, or the CMI. And they stratify populations into 3 different levels based upon these different stratification factors. And again, those are used in this recalculation for the actual number, the expected number. And then finally, we're going to bring in the provincial average and use the provincial average to do a further adjustment on the risk level for a particular indicator. And every one of the indicators go through this same process. Okay, so I want you to be aware of that. They give you some more background information here, some of the things you should be concerned about with respect to that, and then some details on antipsychotics. So that's a handy page to go to under the Health Quality Ontario webpage, and that'll help you understand better where those indicators come from and how they're calculated. And then if you want to go and look at actual results, you can click on the indicator, and here's with living with people with no psychoses, and they're given an antipsychotic. And then you can see here health quality is showing you the graph of how that's been decreasing. Now the only issue here is that you shouldn't really be comparing your current performance to this number. You'd have to make sure that you went back and compared the same quarter. Notice that this is 2015-2016 fiscal. So 16-17 is not on here, and then obviously 17-18 is not on here because that's the current quarter that we're in. So we're looking back, and we know that the current provincial average, according to our slides, is somewhere much closer to 20% or just slightly over 20%. So you can see from 2010-11 fiscal that we've dropped up to the current one, we've dropped a full 15 percentage points, which is absolutely remarkable. And I'm not sure, I think a lot of that came from miscoding, and I think that's been corrected. And however, those results are extremely dramatic results. So notice that they also give you wait times for long-term care in here, and they're showing you that the average wait time, if I remember, was 133 days is the current value. Okay, so the Ontario, and these are comparing both hospitals and nursing homes. So if you look at the nursing home one, this is the wait time, and you can see that up to 2016-17 now, not just the 2015 data. This is right up to 2016-17 that the average wait times have been just increasing and increasing over these fiscal years, and it's all a fiscal year indicator. We also have an indicator for falls, and here you can see that they give you a nice description of the falls. You can see those have actually gone up over time, and it would be really interesting if they would have left the falls in here but also had the restraint use, which is this one. And we click there, and you can see falls have gone up fairly dramatically, but we can also see that restraint use, daily restraint use now, has dropped extremely low from a 16% back in 2010 down to 6% now, which is just a really, really dramatic drop in the use of daily physical restraints. Now, we're also going to look at the pain indicator. And let's go back up here. And we're going to look at pain. Since that's our topic for today, I think we're going to look at pain. There we go. We are going to look at pain. Now, these are just experiencing pain. So we're looking at the prevalence indicator. And we can see that 11.9 or nearly 12% at one point in 2010, and we're down to 6% here at this current point. And we know that we're trying to get to something closer to a 1% level or a 3% level on the pain indicator. Okay, so you can see this lets you at least see where has the province been going over time. If you want to look back at that 2015, Please note that some of these are in 216, 217. Others are in 215, 216. So you'll need to be aware of that when you're looking at it. But it does give you a good sense of where we're going with things. Now, this is one that I'd like to understand a little better, and that's pressure ulcers. And you can see that it's been pretty flat. And the only thing is, I'm not sure why that pressure ulcer rate is as flat as that. Okay, here's where we are looking at a 1% goal. And that means we got to drop by 66% in order to meet that goal eventually, but we haven't made a single move. And if you remember the Carol Estabrook paper, where we said pressure ulcers was the #1 factor that nursing practice could affect. So there's something just not sitting quite right with this particular indicator. Either it does not have the kind of flexibility that nursing practice could impact it, we're not paying attention to it, or the provincial benchmark is way out of line at 1%. So whatever that happens to be, but it is one to look at and just see where it's going. And when you're looking at these numbers on the indicators, notice you can just visit the library to get the full details on each and every one of the indicators. You can download the document that shows the same information and use it for your own internal reporting. There's also some reports that have been published. This one on the antipsychotics is fairly recent. So you can see this one just talks about, gives you a detailed explanation why it's that way, some of the research literature that you can look at, and what have you. So you have a whole wealth of information. Again, please remember that information will not be up to date. It won't be current, and it's going to be more than a year old in some cases. All right, that's it for today, everyone. We'll see you next week. Thank you so much for joining in.